Thank you. And as is customary, the keynote's usually a presentation of the previous year. So there have been some improvements in the presentation from last year, which we can talk about. But I've kept the essential PPT the same as last. This is to basically share the experience of an online training program and how we are training technicians and nurses to do ROP imaging in the rural outreach. It started off as a pilot 2 years ago, and now we've been, besides training, slides have not yet come. Right, so we all know that India leads all the countries in the world in terms of the number of preterm babies born. We have about 35 lakh babies born preterm every year. And if we just extrapolate Government of India data, every 2 hours, 3 babies somewhere need treatment. So in addition to this, there has been a sudden rise in the increase number of government SNCUs and at least a 10-fold rise in the private centers. A recent publication of the Indian ROP Society showed that less than 150 members are actually claiming to be so-called screeners and treaters, out of which there are only about 90 plus who are comfortable doing the treatment. This means that more than 1.5 lakh babies born every year are potentially at risk of going blind. The gold standard of the so-called indirect ophthalmoscopy has been challenged more than a decade back by Michael Treacy, and he said that conventional indirect ophthalmoscopy should be replaced by wide field imaging. We've been doing this program now for over 12 years in Karnataka, where we've been screening. We started off with a few hospitals, and now the entire state is covered, where initially we were taking this RedCam shuttle, and today we take the Indian ROP camera. And technicians and non-physicians have been trained to take these images and upload them, and then the ROP specialists are looking at them on their mobile devices and giving the reports. So today the program covers in 127 SNCUs. We've crossed about 1.5 lakh babies, and over 2,300 have been treated. Conventionally, it takes 30 to 90 working days for some technician to be trained to be able to take images good enough to actually not only take the picture, but to make the right diagnosis. Clearly, that's a lot of time, and no one can spend 90 working days getting trained. Also, how many can we train in a year then? Once they take the image, they have been taught to look at the images and then decide whether the baby needs treatment, needs follow-up, or is completely normal. This we published in the IGO a few years ago, and we have a 20-point training program, and that makes them level 1, 2, or 3 technician. A level 3 technician makes an error of less than 0.5% in diagnosing a baby who needs treatment. The problem then was the duration of training and, of course, the cost of the camera. So the camera has been dealt with in another talk last year and this, so I'm not going to deal with it much, but this is more about the online training. So the camera at that time was just under approval of Department of Biotechnology, but over this past year, they have even gotten FDA approval. This is the online platform. There is a website, and you can see some of the leading names of ROP act as mentors. The entire course material that we use to train these technicians or nurses on site is now ported on this digital platform. And they are taking these courses online remotely and answering all the assessments. There is a very high pass percentage for them to go from one assessment to the other. And only when they successfully go through one can they go to another. What we did in Karnataka was we called all the nurses from all the district hospitals and their pediatricians, and then selected 6 to 7 teams. These teams were first trained for about a week. Then we extended that actually to 10 days now. And these nurses were given some amount of hands-on, on-site, what we call on-site experience. The rest of the training, because nurses cannot be spared for more than a week, 10 days, because they're coming from very busy government centers. So when they went back, male and female nurses would then start using the camera in their NICU itself, and the rest of the training happened online through web-linked video seminars and assessment, both theoretical that they were doing in the comfort of their homes or in their SNCUs. These video mentoring models were not required very often. Initially, it was once a week, and then mostly once a month. And then if they had doubts, then only we would schedule some. So the entire work list from the camera would go up directly onto the cloud. We were able to assess what they were seeing, and if they had any deficiencies of, let's say, not being able to image the ora serrata or difficulty in imaging the nasal quadrant and so on, they were being addressed. This whole thing about trying to I think the keynote has 10 minutes, right? Yeah. The whole idea of training nurses and technicians came from this paper from the London School of Hygiene and Tropical Medicine, which said that ROP screening is now going to move from a doctor and a ophthalmologist base to a nursing and a pediatrician-led base. So that's what we wanted to try and test. This has subsequently been validated using the CDC model. So the Karnataka government gave us what we call the Project 37. We have 37 SNCUs, which have now increased to 40. And that is when we started the 7 district as a model. As we speak, we are training 10 district nurses from Kerala state. And by the middle of May, at least 10 units from Kerala, completely backed by their government, is going to be screening rather getting trained and screening in a similar model. So we worked out the costing. We can reduce costing by more than 23% of the standard. And the duration of training, of course, as we saw from 90 working days to just a few days on site, comes down to less than 1/5. This will impact the amount of cost on site, which is for each SNCU when they have to give out their human resources and their equipment more than 8 times. And our hope for Karnataka is that by 2020, all the district and SNCUs will have enough trained personnel to take care of their ROP screening load, and then private organizations like ours will have to only mentor them to require possibly training for treatment or actually to take care of the treatment itself at some point. For the 10 states, we published this in the IGO, at least about 1,300 babies may require treatment, just looking at just a few of the heads of the states, not even the entire, which means that 700 crores of blindness burden can be prevented just in some of these states, and that's just the tip of the iceberg. This same model has now been adopted in some other countries as well, Indonesia, Thailand, and some parts of Africa. Thank you so much.